Ευχαριστώ πάρα πολύ. Ευχαριστώ πολύ την Οργανωτική Επιτροπή, τον καθηγητή κ. Παπαγγελόπουλο, τον κ. Σουμελή, την κυρία Σαββίδου για την πρόσκληση. Θα συνεχίσω στα αγγλικά και ζητώ συγγνώμη γι' αυτό, γιατί περισσότερους ιατρικούς όρους τους έχω ξεχάσει και είναι λίγο ντροπή, αλλά είναι η πραγματικότητα. So, elbow arthroscopy is a valuable tool in the treatment of several conditions of the elbow. One of the most common indications is removal of loose bodies. So, it's a common procedure, but in the United States, it's not so common among the orthopedic surgeons, because if we look at the data, it's about 7 to 10% of orthopedic surgeons that perform elbow arthroscopy. And the reasons are, it's a difficult joint to scope, as the other speakers mentioned before. There's a fear for neurologic complications because of the proximity of the neurovascular structures. The indications are expanding. There are surgeons that they do release of the ulnar nerve arthroscopically, the advanced procedures. It's an excellent tool for the treatment of early elbow arthritis, which is a difficult clinical condition because elbow arthroplasty is not indicated in most cases in young patients. And the removal of the osteophytes and loose bodies seems to provide some relief of the symptoms, and it's a good approach. We talked about the portals. It's very important to understand how these are established, what structures are around the elbow. I think they were covered extensively by Nikos Darlis. And then one of the pioneers of elbow arthroscopy in our department is Gary Pelling, who actually trained all of us in elbow arthroscopy as residents. And he was the one that he described the proximal medial elbow portal. And when I asked him what he thought about the whole experience, he says, I tried it in the lab and I couldn't believe it that I got into the joint. And if you look at the original publication, he says that gravity protects the median nerve and brachial artery when you do it in the lateral position. So one of the tricks that I learned from him is that when you have a difficult time identifying whether you are anterior or posterior to the intermuscular septum, and you are not experienced in elbow arthroscopy, you can actually use your small finger and palpate the intermuscular septum and verify that you're anterior to it if you're using the proximal medial portal as a study portal. The proximity of the nerves and the neurovascular structures always creates fear, especially in arthritic elbows. And something to remember is that when you distend the joint, as was mentioned before, the distance between the tools, the instruments that you're inserting in the elbow, and the neurovascular structures changes, but the distance between the capsule and the neurovascular structures does not change. So when you are close to the capsule doing procedures, that distance remains the same. Another area that you have to be careful about is to examine patients before surgery. A small percentage of those patients will have a subluxing ulnar nerve, like you see here. And when you place the patient in the lateral position or the prone position, depending on your preference, that ulnar nerve may be already subluxed anteriorly, and that can cause problems. As Dr. Darlis mentioned, another trick is to avoid distal placement of your portals because you're close to the neurovascular structures. And sometimes patients are referred to me with CT arthrograms, thinking that it will be a better test to evaluate for intra-articular pathology, but actually that confuses you more because you don't know what's osteophyte and where you need to pay attention to. So this is a patient of mine. She's 50 years old. She has early elbow arthritis. She has been having stiffness and popping pain for about a year, and she has good range of motion. What I've learned in the years that I've practiced elbow arthroscopy is that it's not only how the X-ray looks, but also what kind of range of motion they have. Because if they have significant stiffness, you might not have enough space to put the instruments in the elbow. So here's the lateral X-ray demonstrating the osteophytes in the anterior and posterior compartments. She was placed in the lateral position. And then the osteoplasty was performed and the loose bodies were removed. This is a loose body in the anterior compartment. When I started doing this, I was using the shaver that I was taught, and for reasons that have to do with safety and time, I decided to move away from the shavers, and I use small hand osteotomes that I placed through the portals. I ostomize the osteophytes, and then I remove them with a tissue grasper. So this is the capitellum on the top and the radial head, and this is the picture after the removal of the loose body. So that X-ray I showed you before showed that there was no space between the capitellum and the radial head, but in reality there was some space. So pay attention also to the range of motion, not only the X-ray. The radiocapitellar joint is difficult to put a shaver in, so you might have to downsize that shaver so you can get an instrument in to perform the chondroplasty. This is a resection of the plica that was shown before by Dr. Dalis, and the arthritic elbow. The posterior compartment is difficult to scope because there's no capsule, there's extravasation of fluid. It's usually at the end of the procedure. Your elbow is already swollen, and if you have time restrictions in the operating room, you can make a small incision and complete the procedure in an open fashion. However, I have had some patients that they complain of pain and tenderness at the insertion of the triceps when I did mini open approaches. I haven't seen it with arthroscopy because we don't go straight posterior. And that's anecdotal, that's my personal experience. This is posterior compartment resection of osteophyte. I have a little video here, but this was demonstrated before of how you evaluate the radiocapitellar joint. And as I mentioned, the retractors are important to improve visualization. They can help you retract structures, because you have a tendency, we like to keep the pressure on the palm very low. So here's a retractor that is placed through the lateral portal, and you can retract the capsule anteriorly instead of increasing the pressure to distend the joint. The osteotomes are important to remove bony prominences, osteophytes, and perform osteoplasties. And here's a video, and the cannula is placed on the lateral side of the elbow, then the osteotome is inserted. Instead of spending a lot of time trying to save this down, you can release it, convert it into a loose body, and then you go with an instrument with a tissue grasper. You grasp that and you take it out. So that decreases your OR time, decreases the fluid extravasation, and makes the elbow arthroscopy easier. You have to evaluate the ulnar nerve before surgery, because these patients have some stiffness most of the time, especially if you are doing elbow arthroscopy for arthritis. If they have ulnar nerve symptoms before, regardless of the range of motion, it's a good idea to perform inside decompression of the ulnar nerve or ulnar nerve transposition. The Mayo Clinic group did a study, and also the study was performed at the Washington University in St. Louis. And they've shown that if you have less than 90% elbow flexion before surgery, and you improve that motion with your osteoplasty or your procedure, 50% of these patients will get some symptoms from the ulnar nerve. So they had to go back and do an ulnar nerve surgery. So in that perspective, it's indicated to do a prophylactic ulnar nerve transposition. The preference of doing an inside ulnar nerve decompression versus a transposition is a matter of debate. I don't think it's something we can discuss right now. And as a last slide, I have here the setup and some tricks that I use to make the procedure easier. So the patient has to lean a little bit on the affected side, not straight up and down. I'm going to pause it so we can see it. When I started doing arthroscopies with Dr. Pelling at the beginning as a resident, we were placing the arm holder close to the elbow, and that was limiting the elbow flexion extension, which is important during the surgery. So I decided to move the arm holder closer to the axilla, secure it so it won't slide during the procedure, and have better range of motion during surgery. Here's the establishment of the portals. You have to always mark the ulnar nerve so you orient yourself. As Dr. Darlis mentioned, it's a little bit confusing because it hangs out like a knee, but it's an elbow. And if you do arthroscopy of other joints, then you can get easily disoriented. So we mark the ulnar nerve almost always. These are the portals. And although they're described in terms of centimeters and palpating structures, I think it's sometimes challenging, especially if you have a very obese patient, to find exactly where you need to be. So palpating bony structures is the way to go for this. I like to use the proximal medial portal because the way I was trained. I know that Scott Steinman from Mayo Clinic starts on the lateral side, which is perfectly fine. So you need to find your own way, the way that you feel comfortable with. This is establishment of the lateral portal, and we do it percutaneously through an outside-in technique. You have to be careful to stay close to the radial head because the radial nerve is very close in that location, and there have been reports of traumatizing that during the establishment of the portal. Let me move this a little bit forward. So here is loose bodies, and they are removed by controlling the suction, the small ones on the shaver. The bigger ones that they cannot go through the shaver, we grasp them. One of the other tricks you have to use is once you see a loose body, you need to stop the flow, and that immediately immobilizes the loose body so you can find it. Because I've been in situations where we have the flow going, we see it for a second, and then the loose body gets lost, and then it's difficult to remove it. So this is pretty much the way I do the elbow arthroscopy. So the take-home message for those is, number one, the joint space is important. Of course, if you have bone-on-bone arthritis, highly unlikely to get into the elbow, and there will be no benefit of doing elbow arthroscopy. The second thing is examining the patients before surgery. Make sure they have good range of motion. If they have a very limited range of motion, you have to explain to them that there may be no space. You might have to convert to open, which is perfectly fine. And then the third thing is to pay attention to your setup. You have to be present, especially if you're in an academic center. We work with residents, because if you can move the instruments or you can move the elbow during the arthroscopy, it won't be a good experience for you and the people you're teaching. Thank you very much.